Hello, everyone. Welcome to our next topic failure to thrive, or also known as growth faltering. Today, we'll be discussing about introduction and definition, normal variant of growth presenting as FDT, etiology, evaluation of child with FDT, which includes history taking as well as physical examination, differential diagnosis, management, prevention, and followed by one case scenario. And I hope all of you all will benefit with this topic today. Let us look into the introduction and definition. As all of you all know, FTT, it is a clinical condition and not a diagnosis. WHO defines FTT as weight consistently below the third to fifth percentile for age and sex, or progressive decrease in weight to below the third to fifth percentile, or a decrease in two major growth percentiles in a short period. It is characterized by inadequate energy intake to meet the metabolic demands of a child to sustain growth. If no intervention is administered, the following are affected: the child's weight, height or length depending on the age, and head circumference. Now, let us look into this chart for the better understanding of the classification of the weight. If the child falls below minus 3 SD, which is in this column, it is known as severe underweight. Anything between minus 3 SD and minus 2 SD, which is in this yellow column, it's known as underweight. And of course, normal is anything between minus 2 SD to plus 2 SD, this white column. And above plus 2 SD is known as obesity. This is an example of growth faltering, which shows the weight for age falls across two major percentile line for age and gender. If you see this chart, his weight for age is less than third percentile for age and gender. So this is categorized as underweight. This chart is an example of wasting because the weight for length is less than minus 2 standard deviation of WHO growth standards. I'm sure all of y'all are familiar with this chart. This is an example of length for age for a female child from birth till 2 years old. If the length of the child falls below minus 3 SD, which is in this red column, then the child is known as severely stunted. Anything between minus 2 SD and minus 3 SD, then it is known as stunted. And anything above minus 2 SD, it's known as normal. This is a WHO chart which actually shows length for age for girls. If you see the length for age, the length for age is less than third percentile for age and gender and actually shows stunting. This table shows the differences between normal variant presenting as failure to thrive. If you can see, genetic short stature and constitutional, usually they have low to normal birth weight, whereas for ex-premature infant, the birth weight is normal if corrected for gestation, and catch-down growth is above expected birth weight. For parental percentiles, ex-premature infant, constitutional, and catch-down growth, all three of them, they have normal parental percentiles, whereas for genetic short stature, the parental percentiles are usually low. If you see progress along percentiles, genetic short stature and ex-premature infant, they have low percentile but does not cross percentiles, whereas for ex-premature infant, the progress along percentiles are low if uncorrected but follow percentile curves, may show catch up to normal range. For constitutional, progress along percentiles may be initial fall in first 6 months and then follow percentiles. In catch-down growth, the progress along percentiles initially fall in 6 to 12 months and then follow percentiles. If you have difficulty to follow this slide, you may pause this slide and go through again. This slide shows about corrected age. Corrected age defined as chronological age minus number of weeks preterm by the American Academy of Pediatrics. Now let us look into this example how to calculate corrected age. Baby Z was born at 28 weeks of gestation. So he was 12 weeks premature. Why do we say 12 weeks? 40 minus 28 weeks. So it's 12 weeks, which is equivalent to 3 months. Today, when he came to you, he is 6 months past the day he was actually born. So 6 months is actually his chronological age. So his corrected age would be 6 minus 3 months. So baby Z is 3 months corrected age. When plotting a baby's growth, it is recommended to use corrected age through 2 years from the original due date. Let us look into another example, how to plot a growth chart of X premature infant. Okay. Baby City was born at 32 weeks of gestation, measuring 34 cm and weighing 1.3 kilo. She remained in hospital until 10 weeks of age. Since discharge, she has been weighed and measured regularly. I'll show the table in the next slide. She is now 10 months old and her parents are concerned that she is not growing well as she is much smaller than children of similar age. They believe that a healthy weight for baby City at 10 months of age is 8.5. So what should we do now? We should actually calculate her corrected age now. So the 10 months is actually the chronological age. So as you all know, corrected age is the chronological age minus how many weeks she was actually preterm. So if she was born at 32 weeks, term is actually 40. So 40 minus 32 is actually 8 weeks. So she's 2 months preterm. So if she's 10 months now, by right, her corrected age would be 10 minus 2, 8 months old. So this is the table that I was telling. So if the chronological, this column here is the chronological age, and the next column is actually the corrected age. So you should minus by 2 months for her age. So if she's 3 months, by right you should tell 3 minus 2, 1 month, and 5 months should be 3 months. 7.5 is 5.5. 10 months is actually 8 months. So if you see, the weight and the length is actually increasing. Now let us plot this into a graph. So this graph actually shows baby City's weight. So at 1 month, this is the corrected age. We have plotted this graph according to the corrected age rather than the chronological age. So at 1 month, her weight is around 3 kilos. At 3 months, it has increased around 4.8. Around 5.5, she's around 5.5. And at 8 months, she's around 6.5. So baby City is actually growing pretty well. Her weight is around the 3rd centile. In the next slide, if you plot the length, at 1 month, her length is around 52 cm. 3 months is around 55, followed by 5.5 months around 62, and then at 8 months is around 64 cm. So she's actually growing pretty well. So when baby City's age is corrected to allow for her prematurity, then her weight and length are both around the 3rd centile. This explains that she is growing well according to her corrected age, and there is no evidence of failure to thrive. Remember, when you plot the graph of a premature infant according to their corrected age and not according to their chronological age. Okay. I hope you can understand the chart and this example. Now let us move into the next slide. Now let us see what actually causes failure to thrive. We have divided into 3 categories. The first category is inadequate energy intake. Example would include reduced appetite, inadequate amount, or diluted infant formula preparation, or is it poverty which is actually causing inadequate energy intake? It could also be structural causes like cleft lip, palate, which is actually preventing the child from swallowing properly. And this can also cause swallowing incoordination. And you have to also check whether the child is having any recurrent vomiting. The second category would be increased energy expenditure, such as increased energy requirement, hyperthyroidism, chronic illness such as heart failure and kidney disease, or the child is having any recurrent infections. Third category would be malabsorption or increased loss, such as pancreatic insufficiency, example cystic fibrosis, or the child is having any abnormal bowel, example inflammatory bowel disease, or is it food protein allergies, example cow's milk allergy, or is just chronic liver disease like fat malabsorption. So it's important to rule out all these causes.
Alright, everyone. Now, let us look at how to evaluate a child with failure to thrive. The cardinal evaluation that we must do is a proper history taking. Our history taking must start with a comprehensive diet history. Ask the parent the amount of food or formula given to the child the whole day. This is to quantify the total calorie intake of the child. Ask if the formula of food is prepared correctly. A too diluted formula may provide too few calories for the child, whereas a too concentrated formula may be unpalatable and the infant may refuse to eat or drink. Thirdly, ask about the type of food given to the child, especially beverages such as milk, juices, soda, and water. Excessive juices can cause failure to thrive. Next, take a history of the child's feeding. Ask when and where does the child eat and with whom. This is to look for any kind of distraction and inappropriate supervision. Ask how the child is fed and positioning during meal times. This is to elicit inappropriate feeding techniques for their age. Try and find out regarding any difficulties while feeding the child as well as food refusal. This could indicate oral or tactile hypersensitivity in the child. Ask what and how often does the child take snacks. Snacking causes early satiety and leading poor meal times in a child. As part of the history taking, don't forget to get further information, the past current medical conditions. A birth history, including complications, small for gestational age, and prematurity, help us differentiate a child with failure to thrive from a small for gestational age baby. Any recent acute illness, such as otitis media, acute gastroenteritis, or recurrent viral infection, may be the reason for poor weight gain, and the child's growth may improve on its own, but these children need to be monitored. Chronic medical conditions such as anemia, asthma, or congenital heart disease could point towards an organic cause of failure to thrive. Stool pattern, including frequency, consistency, and the presence of blood or mucus, is important to plot malabsorption as seen in cystic fibrosis, celiac disease, or any infection and allergies. Ask regarding vomiting, reflux, and other gastrointestinal symptoms to evaluate for protein milk allergy, gastroesophageal reflux disease, and infections. Next, look into the family history, and this includes medical conditions or failure to thrive in siblings, as this predisposes a child to organic or genetic causes of failure to thrive. Ask and check regarding family members with short stature and calculate the mid-parental height. This calculation will be explained later. Ask for any mental illnesses among family members, as caretakers with mental illnesses may be unable to care for a child. Finally, Elicit a proper psychosocial history. Identify who lives in the house and who is the main caregiver. Check how is the family supported and assess adequate quantity of food. What is the child's temperament? As highly strung, colicky children may have feeding difficulties. Look for important stresses such as any economical stresses, intrafamilial dynamics, and major life events, as these may lead to inadequate food supply, depressed parents, and neglect. Any family member with an addiction problem may also cause neglect. This is how we calculate a child's mid-parental height. For a boy, the father's height is added to the mother's height plus 13 centimeters divided by 2. For girls, the father's height minus 13 centimeters is added to the mother's height and divided by 2. Mid-parental height is an estimate of the adult height based on the average height of the biological parents. While it is not the precise indicator of individual height, mid-parental height can provide a rough estimate of how tall is the child likely to be as an adult. For example, for a girl whose father's height is 175 centimeters and mother's height is 162 centimeters, using the formula given just now, her mid-parental height would be 162 centimeters. The potential height that can be achieved by this child when she is an adult is 162 centimeters. Her growth should follow along the 50th percentile to achieve this potential height. Now, let's look at the physical examination of a child with failure to thrive. Firstly, check the growth parameters such as height or length, weight, and head circumference. Do not forget to plot these values into the appropriate growth chart and compare them with the previous parameters. Look for signs of neglect or abuse, dysmorphic features, or any rashes. Using the screening tool 10 4 faces P in a child under 4 years of age would enable you to elicit signs. Using the screening tool 10 4 faces P would enable you to elicit signs of physical abuse. Any bruise in a child less than 4 years old in the regions of the torso, ears, neck, frenulum, angle of jaw, fleshy parts of the cheek, eyelids, and subconjunctiva are suggestive of abuse. In a child 4 months and younger, any bruise anywhere is highly suggestive of abuse, as well as bruises in specific patterns such as slap, grab, or loop marks could also indicate an ongoing abuse in the child. Examine the mouth of the child for any cleft palate, quality of sucking movements, and observe the feeding, including the interaction between a mother and her child. Do a proper chest examination to look for signs of chronic respiratory or cardiac diseases and examine the abdomen to look for distensions commonly seen in malabsorption and organomegaly. Examine the child's gluteal region, as wasting of the buttocks may indicate general muscle wasting. Always remember these red flags when you're evaluating a child with failure to thrive. This includes failure to gain weight despite adequate calorie intake, child with dysmorphism, child with developmental delay, recurrent respiratory, gastrointestinal, mucocutaneous, or urinary infections or illness, recurrent skin infections such as abscess and warts, or recurrent diarrhea, as this warrants primary or secondary immunodeficiency screening and cardiac disorders such as congenital heart disease or heart failure. There are many differential diagnoses for a child with failure to thrive. These may be largely categorized into conditions arising from inadequate calorie intake, inadequate caloric absorption, or excessive caloric expenditure. These conditions may further be divided into diseases of an infant or toddler or diseases of a child and adolescent. Spend some time on this table and understand the differentials for failure to thrive. What are the laboratory studies that needs to be done for a child with failure to thrive? We would normally do a full blood count or full blood picture, as iron deficiency anemia is a frequent cause of failure to thrive, electrolytes, renal and liver function, urine analysis, thyroid studies, specific tests such as sweat test if cystic fibrosis is suspected and celiac antibody if you are suspecting celiac disease, tuberculosis workup, and stool for ova and cyst. Remember that the workup of a child with failure to thrive has to be tailored to each child based on the history and clinical examination. Moving on to management. Early identification of a child with failure to thrive is of utmost importance. Failure to thrive is not a disease by itself, but rather a sign of an underlying problem. It could be a medical illness, psychosocial difficulties, or a combination of both. Identification and treatment of failure to thrive are intended to avoid long-term sequelae of micronutrients deficiency, developmental delay, and suboptimal linear growth. Treatment modalities include dietary changes with an increased calorie intake, behavioral changes facilitated by a scheduled and a structured meal time, and home visitation to document the child's weight, check in with the family, and observe the home dynamics. Hospitalization may be required in severe cases, in child with suspected abuse, and in cases where outpatient treatment has failed. The best way to treat a child with failure to thrive would be to adopt a multidisciplinary team approach. This team should consist of a dietitian, a social worker, a visiting nurse, an occupational therapist, and a developmental specialist if possible. There is an age old saying that says prevention is better than cure. So, how do we prevent failure to thrive? This could be done by promotion of exclusive breastfeeding for early infancy, making combating failure to thrive a community effort, encouraging parenting educational courses, early detection of failure to thrive and to intervene early, prevention of low birth weight, and neonatal screening for treatable metabolic disorders. Let's look at a case scenario that is frequently encountered in our daily practice. Baby Fatima, a 12-month-old female, is brought to you by her mother for a routine checkup. Within the past 4 months, her weight has fallen from 7.8 kgs, which is plus 2 standard deviation, to 7 kgs, which is minus 2 standard deviation. Her height has dropped from 70 centimeters, which is plus 2 standard deviation, to 69 centimeters, which is minus 2 standard deviation. Her head circumference remains along the 25th percentile. Her developmental milestone and her immunization is up to age. On obtaining a diet history, her mother claims that she eats appropriate food for her age, but is sometimes restless and fidgety while eating, and that she does not like the texture of certain food, leading to parental frustration at mealtimes. Her bowel output and her urinary output is normal. She has an unremarkable past medical history. She was born with a birth weight of 3 kgs with no perinatal complications, and there are no endocrinopathies or chronic illnesses in her family history. If you plot baby Fatima's growth parameters In the weight for age growth chart, you would see that her weight has started to falter after 8 months of age. The same could be seen if you were to plot her height in her height for age growth chart, and you would see that the height has also started to falter after 8 months of age. A further history includes the mother's height of 155 centimeters and father's height of 168 centimeters. Other children in the family who were deemed small as young children caught up later in childhood. Mother also describes a history of increased sadness and worry since her child was born. Parents are married and there is no history of abuse or violence in the household. Examination revealed vital signs that are appropriate for her age: weight of 7 kgs, which is -2 standard deviation, and height of 70 centimeters, which is also -2 standard deviation. Head circumference of 45.5 centimeters, which is along the 50th percentile. She is alert, active on handling, and relates well with her mother. Her anterior fontanelles are still open, which is roughly about 2 centimeters. There are 2 teeth seen and 1 just emerging. Thyroid, lymph node, heart, lungs, abdomen, genitalia, nervous system, and skin are all normal. Based on the history and physical examination findings, what are your current impressions for this case scenario? You should have thought of genetic short stature, constitutional growth delay, maternal mental illness, food refusal, or hyperthyroidism. Looking further into laboratory studies, baby Fatima's full blood count, electrolytes, renal and liver function, thyroid function, urine analysis, and stool studies including ova and parasites were all normal. With all the information that was available to us, we should be able to arrive at our final diagnosis, which is failure to thrive with components of genetic short stature with a family history of constitutional growth delay, postpartum depression, child with active temperament and oral or tactile sensitivity leading to food refusal. How do we now manage baby Fatima? A multidisciplinary approach must be implemented for this child. A dietitian referral to assist in devising an enhanced calorie diet for the child, an occupational therapist referral to reduce sensitivity to certain food textures, to manage the mother's postpartum depression, and to arrange for regular follow ups in the clinic every few months for support, ongoing education, and coordination of services. This is our references that we have used in order to develop this training module. These are the list of references that we have used to develop this module. And we would like to thank Dr. Lo Wai Lung and Dr. Madan Mohan J. Munusamy for extending their expert opinion. We hope with this, all of you are more confident and capable of detecting a child with failure to thrive. We also hope that you would be able to carry out certain aspects of the management of a child presenting with failure to thrive. Thank you for your attention.